Hi everyone, this is Kevin Wagner, the Keto Advocate. In January of 2016, I had the privilege to sit down with Dr. Eric Kossoff at the first annual conference on nutritional ketosis and metabolic therapeutics held in Tampa, Florida. Let's see what Dr. Kossoff had to say.
So I'm Dr. Eric Kossoff. I'm a pediatric neurologist specializing in epilepsy. I trained in Buffalo for medical school, and then I did my pediatrics in Virginia, and then came to Hopkins for my training, and I'm still there. So I'm at Johns Hopkins Hospital in sunny Baltimore, Maryland, and snowy Baltimore, Maryland right now.
Could you tell us about the topic you'll be speaking about here at the conference?
Sure. So my specialty within pediatric epilepsy is the ketogenic diet. I help children with epilepsy who don't respond to medications typically. It's most of the kids I take care of. And as a result, they come to see us. We present other options. Ketogenic diet is one of those many options. And so I use it. We do a lot of research in it at Hopkins. I have a big team that's involved in their care. And we enjoy working with those families.
Where could we find more information about you and your work?
So that's a great question. I seem to be everywhere on the internet. The internet is an amazing place. We have a website at Johns Hopkins. If you Google search Hopkins Neurology or Hopkins Ketogenic Diet, our website will come up. I run a blog on epilepsy.com. It's www.epilepsy.com. Which is the site for the Epilepsy Foundation, and a site called epilepsy.com that started many years ago. It's probably the largest site for epilepsy in the world. And so I run a blog on there called Keto News, which is devoted to dietary therapy. Probably about every 2 months I update it with things like this meeting and exciting things going on, and parents, caregivers, families, patients can all log in and read about what's new in the field. That's what I tell a lot of families who are interested in the diet, is to go to that site. Other good sites like the Charlie Foundation and Matthew's Friends will talk about our research and things that we're doing too. So we're very active actually now with our adult center. So many of our studies at Hopkins now involve adults going on ketogenic diets to see who responds better. Do they respond differently than children? Are there aspects of management of those adults that will help make them do better? Compliance can be an issue for adults going on dietary therapy, and that's an active area we're trying to help improve, so to make them more compliant. But we're still very actively looking at our pediatric population. Again, ways to make the diet work better, prevent side effects, try to find those ideal subjects. There's some interesting ideas about who they may be, and so we're working on those. It is amazingly quick, unlike some of the therapies that we have out there. So if you look at studies of children who are having almost daily or monthly, very frequent seizures, usually within maybe a few weeks to maybe a month or two on seizure calendars, you can detect the difference if they're going to respond. About 85% of children will respond within about 3 months. So as a result, we tell families, if you're going to give this a try, give it a good 3 months. There are outliers. There are some families that 4, 5, 6 months into the diet, that's when they start improving. They're rare, but knowing that, we usually still try to go for a full 6 months before we would give up on the diet. But it's a commitment. It's important that we tell the families that, because they know it's hard and they don't want to do it forever if it's not helping. Right. So we tell them to give it 3 to 6 months. So no matter where in the world you are, no matter your age, no matter your gender, even no matter what, to some degree, what diet you do, the numbers are strikingly similar, which is that about 50% of children will have at least a 50% reduction in seizures across all those age ranges. And that's what I tell families. I say, you have a 50-50 chance of doing well with the diet. If you subdivide out and you say, okay, of those, how many become seizure-free, it's about 15% overall that become seizure-free. So 50% responder rate, 15% seizure-free. May not sound impressive, but when you compare to sort of responding to the next drug after several drugs have failed, that is about a 30% responder rate and about a 2 to 3% seizure-free rate. So the diet comparatively looks quite good. And there have been studies to compare that have shown that the diet does look better in that situation. But again, that's where the research is going, trying to find who those seizure-free children are, knowing who they will be so that you're going to do better than a 50% responder rate. Absolutely. So we tell families for children, okay, we'll talk about adults in a few minutes, they're maybe a little different. For children, we typically say, like a medicine, our plan is 2 years. Okay, we're going to use this therapy, be it again diet, be it drugs, for 2 years and then reassess. And the reason we do that is we know a lot of pediatric epilepsy will resolve. Even the very tough cases, even ones you wouldn't necessarily expect them to improve, they surprise us. And so children, not even necessarily who are seizure-free, even who have a modest response, usually at 2 years, we'll try to wean them off the diet. Knowing it has side effects, knowing it's difficult, we tell families, let's see if the diet maybe has done its job. That's often how we describe it to families. And so typically at about 2 years, we'll at least broach the subject. And every child's different, but we'll then try to slowly wean the diet and see how they do. If the seizures start coming back, we can always go back on the diet. But about 80% of children successfully come off the diet at 2 years without worsening of their seizures. Wow. Adults are a little different, though. Adults tend not to stop. It's very interesting, my experience. They tend not to want to stop. On the adult center, I tell them, you know, what we do in children, and on the adult center, they, if they're driving, if they're doing well, they're not going to stop. Like, see you in a year.
Yeah.
Like, okay. It's interesting. Yes, there are very select epilepsies that seem to be very responsive to the diet, such that by being on the diet for those conditions, you could affect a cure. One condition is called infantile spasms, okay, which is a age-dependent epilepsy, very severe, affecting 6 to 9 month olds. When you go on the diet, if it works, seizures stop, and 6 months later, we usually take them off the diet, cured. Okay, we may see them here and there for other issues. Some have underlying etiologies that led to the seizures, so they may need to come see neurology, but their epilepsy is cured. There's another condition called DOSA syndrome. It's like, looks like Doose, D-O-O-S-E. It's a German neurologist who described a very specific kind of epilepsy as well that affects typically 4 to 5-year-olds with drop seizures. They do amazingly well on the diet, and then 2 years later they're cured, and give them hugs at parties, see them at baseball games, and never need to see a neurologist again.
Do you ever see this happen with kids on drugs, using drugs too?
Drugs can do it too for other kinds of epilepsies. There are some bit more, as we call them, no epilepsy is completely benign, but there are some benign epilepsies relatively that we know are age dependent. We know when puberty comes, they're going to go away, even without drugs. But there are definitely children who do very well with drugs too. As a non-basic scientist, I can tell you it is very complicated. If you asked me this question 20 years ago, there would have been one answer, which is the diet is called a ketogenic diet for a reason. It induces ketosis. Ketones affect your brain, help suppress seizures like a drug. Which ketone is debated? Acetone isn't usually thought of as the effective agent. It's more beta-hydroxybutyrate is what people think. Although even that's debated a little bit. And that is the answer. Now, 2016, much more complicated, such that, you know, there are children and there's evidence that ketones may not really be that relevant for some of them. And so we check, we keep an eye on them. There are some children who seem to be sensitive to ketones for whatever reason, but most are not necessarily. That's my clinical scientist answer. It's complicated. So, you know, 2DG is very interesting, and I think it speaks to the larger world, as we often hear from the basic scientists, of metabolism-based therapies, that the ketogenic diet is a very complicated therapy, but if you tease apart different aspects of it, you may get benefits, okay? And it may be that, as you mentioned before, ketones may be helpful, such that giving ketones, ketone esters or other options may help certain epilepsies. Similarly, 2DG speaks to what anecdotally others had noticed, that maybe it has something to do with keeping your carbohydrates or glucose low, okay, or stable. And what 2DG does is block the glucose uptake. And so it seems to work. Now, is that the ketogenic diet? Studies say probably not, that if ketogenic diet in animal models and 2DG are totally different, which is interesting, yet they both work in different ways. So it speaks to the fact, again, that, again, as a clinical scientist, hearing all of these talks and knowing what I know and have heard, it's probably many different mechanisms.
Right.
But it's intriguing. And it suggests, and what I tend to do is use or think of these therapies as an adjunct. So if you're on the ketogenic diet, what would happen if you added 2DG?
Right.
That would be very interesting, but we're not there yet.
Okay.
They do exist. Parents do come to me sometimes asking about the ketogenic diet, and for various reasons, I'll say I don't think it's a good idea. I think that we know that there are certain metabolic conditions where the diet is contraindicated. They tend to be ones where you can't break down fats, so fatty acid oxidation defects, porphyria, primary carnitine deficiency, mostly metabolic conditions. We try to screen them out with labs before we start the diet. All children get labs before they start the diet, but every once in a while a child may slip through. But those are mostly metabolic conditions. There are some children who we can't assure their nutrition. That can become an issue, where my dietitian, Stacy Zahava, will say, for various reasons, I'm very worried about this child's ability to eat and get nutrition in. The diet could be dangerous in that situation. And we may really say, look, we need to work on nutrition and eating before we think about this kind of a therapy. So that may be a contraindication. The other one, is actually kind of compliance. This is a tough therapy to do. And so sometimes when I'm talking to a family and interacting with them, I'm not so sure that they understand what's involved. I'll tell them to read some books. I'll tell them to go on the internet, talk to some other families. Yet at the end of the day, I'm not sure they understand the complications and the risks and the commitment that's involved. I'm not sure that's necessarily a reason not to. You could try to work with them, but it does come up, and we will sometimes say, let's try something else, until this family is really ready for that kind of commitment. Right. But there are no specific epilepsies that it's contraindicated in. We know there are some epilepsies that may not work as well. Some partial epilepsies that may not work as well, for example. Doesn't mean we wouldn't try it, if the family really wanted to.
So are there certain epilepsies that it does work better for?
Right, so infantile spasms, it works very well. DOSA syndrome, as I mentioned. Another condition called GLUT1 deficiency, very effective for that condition, shockingly effective, almost 90% of children respond. So we do know some of these conditions out there. It's another question that depends how much time you have. I think it all speaks to just how creative dietitians and parents are in so many of these diets that are currently available. I think it's great. They're all variants of a same theme, though, when you really kind of look at the composition of these diets. Although in some ways they may seem very different, they're actually more alike than different. They're all essentially high-fat, low-carb diets with just varying levels of how much of either one. Modified Atkins diet, low glycemic index treatment are considered what we call alternative diets. So done usually as an outpatient without a fast, teaching them how to do it in clinic. Yet they're still low-carb, high-fat diets, but they don't involve the weighing and measuring and calculating that the classic ketogenic diet or the MCT diet do. They still do require dietitian involvement, but probably less of the strict management that's involved. We're thinking more of some of these alternative diets for adults, for teenagers, for some of the non-epilepsy uses. People have talked about this being a more rational option than a classic ketogenic diet. Right. Now, a lot depends on the case, a lot depends on the family. More and more with the internet, families are coming to me knowing which diet they want. Often they're right. I say, yeah, that makes sense, that's reasonable. There are some situations where I feel strongly one versus the other, but we tend to be very much in favor of the classic ketogenic diet for infants. You can really carefully control what they're getting. Plus, the advantages of an alternative diet kind of go away when there's a formula, because the ketogenic diet and a formula is relatively straightforward. Whereas in adolescents and adults, we really lean towards the modified Atkins diet, just a lot easier, a lot less restrictive on an adult to do.
Right. Have you found in general that you don't have to be as restrictive as maybe
the outcomes look strikingly similar so far? Almost all the studies that have been head-to-head have shown that they're relatively equivalent. But in a way, we sort of think that these are like different levels of a drug. So it would make sense. Low levels of a medicine may work, okay? And if it doesn't work, you go to a higher level. That's, in a way, how as neurologists we think about these diets. I tell families the modified Atkins diet is kind of like a low dose of the classic ketogenic diet. And they say, oh, well, then we should do a high dose. I say, well, the low dose may work, and that's why I want to try that first. Right. But if it doesn't, then yes, we might switch over to the classic ketogenic diet.
Right.
It happens on occasion if children are ill or dehydrated or not eating well. They can sometimes become acidotic, and then we see some symptoms. We may see vomiting or nausea, flushing. Their face gets flushed and red. So we spend time teaching families about these signs, how to watch out for them. Thankfully, it's pretty rare, but when it does happen, we have to be pretty aggressive to try to keep them hydrated, and usually it passes pretty quick. Sure. So, all sites are different. Some sites do not admit, some sites do. Our site, it still routinely admits children for the classic ketogenic diet. There's a lot of advantages to doing that. I think they come in, they meet with our ketogenic diet team. They get sort of almost like an epilepsy ketogenic diet boot camp. They learn intensely over 3 days how they need to do the diet, the weighing, the measuring. It can be done as an outpatient, but it requires a lot of back and forth visits. So we have them as sort of a captive audience in the hospital to really do all the teaching that's necessary so that when they go home, they are experts in the diet. It also allows us to watch them as they go onto the diet. Some children do get into trouble, they have vomiting or other issues. They're in the hospital, they're in a safe environment. They can sometimes have more seizures, just as their metabolic changes happen. So I think we prefer to have them sort of very closely monitored. It allows for, if there's problems, hypoglycemia like that we can adapt very quickly. You can do it as an outpatient, but that's, again, our preference to do it as an inpatient. The greatest challenge? That's a good question. Every child is their own challenge, I think. But the ones that I think are personally the hardest that I'd love to have a good answer for are the ones who do very, very well, and then they lose that control. We know that happens with medications too. Those are ones we really don't have good answers for. There are a lot of things we can do to fine-tune and tweak the diet, and we've heard at this conference about a lot of different supplements that people are working on. Yet, I think there is something intrinsic in some of these children that they do tend to, we call them honeymoon. And it's a problem in the keto community as a whole. When I get emails or calls from other centers asking me advice, it's often that situation. They say, we believe in the diet, we've seen it work, yet the seizures came back, and we don't have a good explanation for why. Everything has been perfect on the diet. So that's a definite challenge for me and for my team that hopefully we'll have better answers as the next years come by. So there can be. Long-term sort of is for us defined as sort of over 2 years. We've done studies of children on 6 or 7 or longer years. We know growth can be impacted. The longer you're on a ketogenic diet, at least a child, we do see some impact on growth. Not as much of an issue for adults as you would imagine, they've done their growing. Things we've done to try to fix that have not been completely successful. People have given vitamin D, they've given calcium. It's not clear how much of a difference it really makes in linear growth. So that is one of the biggest long-term effects that we have to watch. And I depend a lot on my dietitian to help me to try to improve that in those children. We historically used to see more kidney stones in the long-term ketogenic diet patients. The risk went from 6% short-term to 25% long-term at some point in their time on the diet. Now with some of the supplements that help alkalinize the urine, we don't see that as much. So I don't refer to that as a long-term side effect as much anymore. Growth for sure. Bone fractures are also something that's been identified as a long-term benefit. Long-term side effect. Excuse me. So that's something we have to work on too. So the mandatory ones, as far as the 2009 consensus study, were multivitamin, calcium, vitamin D, and the multivitamin should contain some trace minerals too, zinc, selenium. Those are probably the key supplements. However, lots of extra supplements are being used. We use something called citric A to help prevent kidney stones. I personally think that should be mandatory. Some people will give extra carnitine. Some people will give extra vitamin D above the recommendations. Some people will use things like Miralax to help constipation, and many children are on that. So a lot of these children do end up on lots of extra supplements.
Okay.
I can tell you a little bit. So triheptanoin is an oil that has been used for some children with GLUT1 deficiency as potentially an alternative to the ketogenic diet. It's an interesting compound, but we don't have enough evidence to say that it's either equal or should supplant the ketogenic diet. A lot of the families with GLUT1 are very interested in it, and there's been some studies looking at using it for GLUT1 deficiency with early intriguing results. But at least at this point, it's not the primary recommended therapy for those children.
Okay.
You went back to my blog. So that was a paper from Dr. Evangelou from Greece, which was very intriguing. It was the start of what we're now seeing more of in terms of using something to supplement a child on the ketogenic diet as a way to improve efficacy. And since that paper came out, people have started down the road of looking at these supplements, but none really have gotten any sort of really good data to say that they're beneficial for children on the ketogenic diet. What he did was he added branched-chain amino acids, large quantities. It was a little tough for the kids to take, but he added it to children who were on the ketogenic diet yet did not have control or had lost some control. Very practical, as I mentioned, a very practical issue, and found preliminarily some good benefits. So it was very intriguing at the time. And I think people have looked back at that study and others and said, hey, what about trying other compounds? Adding MCT to a child on the ketogenic diet, adding carnitine, adding ketone esters perhaps, triheptanoin as you mentioned. So I think it's led to people looking at different ways to supplement the diet, which is great.
Right.
Yeah, so there are lots of good books some written by parents with recipes. There's a book coming out that Susan Massino is the chief editor of that's going to be very much based on science and scientific evidence on the ketogenic diet with multiple authors. Our ketogenic diet book is now about to be in its 6th edition. And so for a few big reasons, there's some good changes coming to the book, and as every new edition has lots of changes. The title is changing. It's going from Ketogenic Diets, Treatment for Epilepsy and Other Disorders to the Ketogenic and Modified Atkins Diets, Treatments for Epilepsy and Other Neurologic Disorders, reflecting, number one, that there's a lot of interest in the Modified Atkins Diet. And even though our 5th edition had probably about 5 or 6 chapters on the Modified Atkins Diet, one common request we had from parents was they said, is there a book on the Modified Atkins Diet? And I would tell them, yes, it's our Ketogenic Diet 5th edition, and they didn't realize it maybe because it wasn't in the title. So we added to the title to make that clear, and we expanded the section on the Modified Atkins Diet, both recipes as well as tips and tricks we've learned. I guess it's in the last 6 years since the last edition came out. We also had, back in the last edition, maybe a one chapter that was devoted to cancer and autism and Alzheimer's, and was very hypothetical and said, yeah, stay tuned, this is getting exciting. Now we have a whole section with different authors writing as a chapter on cancer, a chapter on autism, a chapter on migraines, and a chapter on dementia. Those are the 4 chapters in that section. It's still very preliminary, much of this, but devoted chapters to those topics. And then as well, We changed the authorship slightly, and so Dr. Freeman now passed away. I'm remaining as an author, but we also have two of our adult specialists popping in as authors. So Dr. Mackenzie Cervenka and Bobby Henry, who's her dietitian from the Adult Diet Center, are now authors of the book as well, reflecting how much the use for adults has increased. So there's a whole section now on adults where it was just a chapter before. Right. It's definitely a different book.
Okay. When should we be able to get our hands on the new book?
End of March 2016
Great.
is when I hear it's coming out. Very exciting.
Great. Congratulations.